Good afternoon, everyone, and welcome to another INNEG webinar. Today, this session forms part of our INNEG birth injury series, where obviously we focus on how expert evidence is applied in the complex claims and the sector of birth injury. Today, we are looking at hypoxia in birth injury claims with a particular focus on how obstetric evidence is used to address the disputes around timing and causation. And we are delighted to have Dr. Benjamin Viaris de Lesegno here with us today to speak to us. Before I pass you over to him and introduce him formally, I thought it'd be interesting to advise our viewers today of the fantastic array of expert disciplines within the paediatric sphere that INNEG have access to and can offer you, whether it's in the birth injury sector specifically, and we're talking about neonatologists, obstetricians, pediatricians, all the way through to pediatric neurologists, pediatric neuropsychiatrists, and even pediatric care reports. If it's a medical related discipline, you can go onto our website and you'll be able to see the number of experts across our database within each of those disciplines. Reach out for a free, no obligation quote, and if we're able to source an expert for you, we'd be delighted to assist. That aside, I'm very pleased to welcome, as mentioned, our speaker today, Benjamin, Dr. Benjamin Viaris de Lesegno. He's a consultant obstetrician and gynecologist with a subspecialist expertise in maternal and fetal medicine. And alongside his practice in high-risk obstetrics, he has developed medico-legal experience as an expert witness. So I'm sure he will also give us an insight to his practice in his presentation. So without further ado, please, may I introduce you, and thank you very much for being here today.
Thank you very much, Leo. Hello, everyone. Leo, I have to tell you, you did wonders with my last name. It's very rare that English-speaking people manage to say Viaris de Lesegno, but you did great.
Thank you very much.
Thank you. Good afternoon, everyone. I am very excited to do this presentation. I want this to remain an open conversation. So if you have any questions, you have a Q&A option at the top where you can write your questions. And if I will not be monitoring the Q&A all the time, but Leo can interrupt me, or you can put questions in the chat. Feel free to ask questions along the presentation. I think it makes it more lively than all the questions pile at the end. We are going to talk, as Leo said today, about hypoxia and birth injury claims, and we're going to focus on the evidence in obstetrics with regards to timing and causation. And we're going to focus on where disputes arise in timing and causation cases. First, a small introduction about myself. As Leo said, I'm a consultant in obstetrics and gynecology. I have a subspecialty in maternal and fetal medicine. I am French. I was a consultant in the French healthcare system, moved to the UK more than 10 years ago. I've been a consultant for 14 years, and I started working in maternity risk management when I was only a junior doctor. And so I've been working in maternity risk management for more than 20 years now. I am currently a substantive consultant at the Hillingdon Hospital NHS Foundation Trust, which is within the Greater London. I have an MD in fetal medicine and a master's in genetics. And I passed my Cardiff University Bond Solon certification in 2024. That's when I started being an expert witness. And I've been working on a lot of birth injury claims since I started. A quick reminder of why do birth injury claims matter. I think everyone here is acutely aware of the weight of obstetrics, but nevertheless, doing this presentation gave me the capacity to look at the data in the latest NHS resolution report. I am not going to define NHS resolution. For those who are maybe younger in their career within our crowd, NHS resolution acts as the lawyer and the insurer of the NHS. The most common claim specialty is emergency medicine with 13.9% of claims. And the second one is orthopedics at 11.5. Obstetrics comes as third, and together with the early notification and the non-early notification claims comes at 11.2%. So it's the third most common. Know that there are more than 40 different care specialists within categories within the NHS, and so the distribution is clearly uneven between emergency, orthopedics, and obstetrics. Now, you can see that obstetrics is the third most common in terms of numbers of claims, but in terms of value of claims, it is by far the most common. The second data point is that if you put together the value of the clinical claims between non-early notification and early notification, you are already at 52% of all value of claims. And emergency medicine, which is the second, is only at 7%. So there's a huge discrepancy, and obstetrics is by far what the NHS pays for through NHS resolution. All in all, 62% of all total clinical negligence provision, and that means the value of the claims and the money spent in lawyers, experts, and supporting those claims or fighting those claims. All in all, that's 62% of the entire budget of NHS resolution. So it is by far the most important segment of resolution in the UK. Hypoxic ischemic encephalopathy and hypoxic ischemic injury in general accounts for 60 to 70% of all total maternity claim cost. That is huge. Any birth injury claim involving hypoxia, cerebral palsy will result in a settlement that will land between 10 and 40 million pounds. Because as you most likely know and understand all, you have to pay for the care of that child for the rest of their life, including all of the potential loss of income of that child. You have to pay for the organization of their care, and that can include a van for the wheelchair, 24/7 nursing, or building a ramp at the entry of the family home and all of that. You also have to pay for the loss of income of the parent, which becomes the carer. So all in all, between 10 and 40 million per cases. When you look at the NHS Resolution 10-year report that was published in 2010, you see that 50% of severe brain injury cases reviewed show elements of suboptimal care. And so that's why we're going to talk about that care. And we're going to talk about also human factors, which represents 30% of those 50%. You can see here a graph from the latest report, 2024-2025, and you see that the total number of obstetric-related cerebral palsy or brain damage claims is actually fairly stable. There has not been any improvement. The implementation of the early notification scheme means that we are expecting a small decrease in 10 years from now. So we're expecting those numbers to go down because we are footing the bill earlier, and we are working earlier on the cases done through the early notification program. So I have this slide because I use it with junior doctors who I work with, but I'm assuming everyone here understands clearly what is the Hunter test, the Bolam test, or the Montgomery tests. These are the angles through which I look at each cases. So they're all defined by jurisprudence. If you look at Hunter v. Henley, the question is there a usual and normal practice? Was the treating doctor adopt that practice? And is the course adopted one which no doctor of ordinary skill would have taken if acting with ordinary care? And this is supplemented through the Bolam test, which is if that course is not the usual and normal practice, is there a responsible body of medical opinion that can support that practice? And did that doctor explain the reason why, rather than using usual practice, they used a practice which is recognized by a responsible body of medical opinion. Finally, of course, Montgomery, any care carries an inherent risk. The doctor has the duty to disclose the risk of all care, including expectant management, which can feel like no care at all, but expectant management is not no care, it's expectant management. They have to explain the reasonable alternatives, including expectant management. And what is important is judging from the patient's perspective. What does a reasonable patient would want to know? Now, we are going to use long and painful words during this entire presentation. And so I wanted to make sure that we are aligned in terms of definitions. I tend to speak a little bit too much in medical lingo. So if there is any word that we have not gone through the definitions here or the next two slides, and which I use and that somebody does not feel is very clear, just feel free to interrupt me, put in the Q&A or in the chat, and Leo or Jessica will interrupt me to ask the question. So hypoxia, from the Greek, hypo, not enough, oxia, oxygen, reduced oxygen in the bloodstream, antepartum, before labor, partum, the labor, anti, before, perpartum, during the labor, and peripartum, around the labor. Acidemia means the pH in the blood is low. We define severe acidemia as a pH inferior to 7.0, and we will come back to that number. And finally, when we talk about asphyxia, we mean total failure of gas exchange. That means there's both hypoxia, not enough oxygen, hypercapnia, too much CO2, and acidemia, which is secondary to the increased hypercapnia. So all of that means asphyxia. I will not go into all of the nuances of all of those definitions when I talk about it, I can reassure you, but I just wanted to make sure that we all use the same lingo. Now, the next important definition is one of hypoxic, ischemic, encephalopathy. Hypoxic, not enough oxygen, ischemic, not enough blood, encephalopathy, pathology of the brain. So there is no single definition in the UK of HIE, but what really matters is when do you treat HIE? And there is therefore an operational definition that is used across the different national frameworks. What really matters in HIE is that you can decrease death and disability by doing therapeutic hypothermia. So you take the entire core temperature of the body to 33 or 34 degrees for 72 hours. What happens is that you decrease the need in oxygen in the brain and the most important organs, heart and brain and others, during those, from the effect of that cooling. And therefore, the fact that there was less oxygen at one moment makes it that those cells survive better. They have time to heal, and the mechanisms that lead to acidemia and further cell damage, which are healing mechanisms secondary to that hypoxia, do not take place. And so if the cells are dead, at least the healing mechanism and the clearing mechanism of those cells that are dead does not damage the neighboring cells. So to be eligible for therapeutic hypothermia, a child that has HIE, so hypoxic, ischemic, encephalopathy, because it's a big word, I'm always going to say HIE from now on. A child that has HIE needs to meet 3 categories of criteria. And so first, it needs to be 36 weeks or more, it needs to be admitted to NICU, otherwise you may have some signs on the EEG, the electroencephalogram, or on the MRI, but if the neurological state is not bad enough that the child is not in NICU, it's not HIE. And then you need to have a certain amount of things. You need to have an APGAR score, one of the 3 following, APGAR score less than 5, or continued need for resuscitation, or acidosis, severe acidosis with a pH of less than 7.0, or increased base deficit at more than 16 millimole per liter. That's the category A. Then you need one of the category B, which means that on top of having metabolic troubles, you need to have an effect on the brain. And so there needs to be at least one of those, either hypotonia, so the body is floppy, or abnormal reflexes, or absent or weak suck, the baby can't feed, or seizures. And finally, you need to prove that it is related to a metabolic damage of the brain. It's not only that you have metabolic problems and you have a brain problem, you need to put those two together, and you do that by doing an electroencephalogram, and you show abnormal background activity or seizures. That's HIE. And HIE is responsible of, in most cases, cerebral palsy. So cerebral palsy is an umbrella term that talks about all the problems posed by HIE and other conditions downstream, and which happened via damage of the white matter, the ganglia, certain infarcts inside the brain, or other problems inside the brain. And so it's organized. They can, depending on the origin and or the symptoms, cerebral palsy can be organized in different manner. You can have sensation, perception, cognition, behavior, communication, epilepsy, musculoskeletal problems, and all of that. You define them by the type of problem. It can be spastic, which means the muscles are so tight that you can't move at all your joints. It can be dyskinetic. You can't move in a coordinated manner. Ataxic, you can't walk. You can't not only control your own body, but control your body within the greater environment. And it can be mixed. It can be diplegic, so either half the top or half the bottom. Quadriplegic, all of your limbs, or hemiplegic, both the right limbs or both the left limbs. So, for example, my cousin had a hypoxic, had an HIE, which resulted in cerebral palsy. He can't move all the right side of his body, so he has a spastic cerebral palsy, which is a hemiplegic spastic cerebral palsy. He can't move his right arm and his right leg. That's how you think about it. Now, once we understand all of those definitions, let's try to talk about causation. The main question that is going to be asked is, did this happen during labor or before labor? It will not reach me if it happened after labor. It will reach a pediatric neurologist, not an obstetrician. But there are multiple cases of HIE which are related to events that happened after labor. In my case, the question I'm going to be asked is it related to labor, or is it related to an event that happened before labor? So is it perpartum or antepartum or antenatal? Antenatal, when there are hypoxic injury, there's different processes that are possible. When you think about the pregnancy, you need to think about 4 separate entities. You need to think about the fetus, you need to think about the mother, you need to think about the placenta, and you need to think about the uterus. In the case of hypoxic injury, you can equate the uterus and the mother, because rarely do we have to differentiate induction to spontaneous labor. But sometimes you can't, and you have to think individually of the behavior of the uterus without the control of the mother, because as we all know, the mother has very little control of her uterus. So if things that can lead to hypoxia before labor, the leading cause is placental insufficiency. The placenta is that organ that sits between the mother and the baby, and whose purpose is to extract oxygen and nutrients from the maternal blood flow and provide them to the baby. The bigger the baby, the bigger the placenta. If your placenta is not functioning normally, it cannot extract oxygen and nutrients from the maternal blood flow and provide them to the baby. Therefore, the baby does not grow as much. The baby usually presents growth restriction. either fetal growth restriction, which is the severe form, or small for gestational age, which is the milder form. But you can have a placenta that does not work and that is nevertheless big enough to be able to extract enough oxygen and nutrients that the baby grows well. But it will, in that case, usually still be visible through signs on the maternal side. That's what usually leads to preeclampsia. It is common to see preeclampsia without growth restriction, even though most preeclampsias have fetal growth restriction. What is preeclampsia in itself? In preeclampsia is the placenta is not functioning well enough. The placenta has mechanisms of communication with the maternal body. And so it says, I am dying here. I am not being able to extract oxygen. I feel like I'm out of breath. I would like you to send me more blood. So I'm increasing the blood pressure in the mother because I feel like I need more blood. And so that leads to hypertension, which then leads to different organ failure, including the kidney, which is the definition of PET, high blood pressure related to the pregnancy in the second or third trimester with protein in the urine. So at least one sign of organ failure. Those can be preventable. There's a lot of cases where antenatal hypoxia is not preventable because you don't control the placenta, you don't control the uterus. There's lots of events that can happen before, but they could be preventable. For example, aspirin in preeclampsia. I'm actually right now working on a case where one of the questions is, was the aspirin treatment put in the proper way, instigated and continued in this patient in the proper way? And so you may not know, but the ASPRE study has shown that if you select a population that is at high risk of preeclampsia and you give them aspirin 150 milligram once a day starting before 14 weeks and until 36 weeks, you divide the rate of preeclampsia by 2. So you decrease by 50% the rate of preeclampsia. That is a huge improvement. Those are for more chronic or evolving processes, but you can have an antenatal hypoxia, which is related to a single event. For example, placenta abruptio. There was at one point, for some reason, a major hemorrhage between the placenta and the uterus, and therefore a hematoma, a collection of blood, has created itself in between the placenta and the uterus, which means the placenta cannot exchange its gases and capture nutrients anymore because it is fat in front of a clot. It is not connected to live vessels. And that is placenta abruptio. That can happen perpartum or antenatally, and that is the perfect example of an acute event antenatally. Usually, placenta abruptio are major. They involve more than 50% of the surface of the placenta, and they lead to labor immediately by reaction on the uterus. But it is possible that you have a small placenta abruptio of less than 25% of the surface of the placenta, which leads to antenatal hypoxia, but does not lead to labor. Now let's talk about hypoxia during labor. Hypoxia during labor, there are many things to understand. The first one is, what are the risk factors related to it, and what does that mean? It means what is the state of the mother and the baby, and how much capacity do they have to handle some hypoxia or repeated small hypoxic event. And how does that impact the uterus? How does that impact the placenta? How does that impact the baby? You can simply have a baby that has a placenta of low quality, but not bad enough that there was fetal growth restriction or maternal preeclampsia. But nevertheless, this placenta has a mild form of placenta insufficiency. And therefore, this baby metabolically is on the verge. It's okay, but it has no reserves. And so then what you do is you pile on lots of contractions, and during every contraction, because of the increased pressure inside the uterus, there's no more blood flow. The pressure inside the uterus is bigger than the arterial pressure of the mother and the blood pressure of the mother, and therefore during that contractions, there's no more blood flow. So it's like holding your breath for 2 minutes at a time, 3 times in the time of within 10 minutes. So I hold my breath for 2 minutes, and then I can breathe for another 1.5 minutes, and then I hold my breath for 2 minutes, and then I can breathe for another 1.5 minutes, and then I hold my breath for 2 minutes. I can do that only if I have a good cardiovascular system and I have good reserves in energy. If I don't, after a while, I will start to decompensate. And that leads to hypoxic event intrapartum. At least that's the best way to represent it. So if we look at the indicators of antenatal hypoxia, could there be placental problems? Is there PVB means pervaginal bleeding? That's a sign of a partial placenta abruptio. Do we know on the ultrasound there's an infarct inside the placenta? Was there aspirin or not? What's the appearance of the placenta on ultrasound? You can see calcifications, which are signs of vascular problems inside the placenta, etc., etc. On the fetal side, is there an SGA? That's the milder form, an FGR, that's a more severe form, or a decreased growth velocity. That's a notion that has appeared in the last 10 years that did not really exist 10 to 15 years ago, which is the idea that if you were a bigger baby, a baby around 70th centile, for example, during the entire pregnancy, and suddenly you're still a normal weight baby, but you're on the 20th centile or on the 30th centile, you've gone quite fast between a high centile to a low centile. That's a sign that your placenta does not have the capacity to feed you as much as it should be, because you're not achieving your full potential of growth. So that's called decreased growth velocity, but you still have a baby that is considered within normal weight, but you know that that is not its own potential. You can see abnormal Dopplers, so that's abnormalities of the blood flow in different vessels on the placenta, on the cord, uterine arteries, inside the brain of the baby, and all of that. You can see oligohydramnios. That is really interesting. Oligohydramnios is the idea that there's less amniotic fluid, and when you don't have enough oxygen and you have nutrients, if you are starving, your kidneys will shut down first as a human. And amniotic fluid is 99% urine from the baby. So you can see first, before any of the other symptoms, a decrease in the quantity of amniotic fluid. That's oligohydramnios. Reduced fetal movement is really important, because if the same thing, if the baby is not fed enough, the baby doesn't have enough energy, the baby's not going to move. And I've repeated here what I've said earlier, abnormal Doppler studies. Now, there are signs on the maternal side. Is there any risk factors that tell us that there are things that are more likely to happen during the pregnancy? Does the mother has cardiovascular problems and therefore low quality vessels, and therefore it's more difficult for the placenta to extract oxygen and nutrients from the maternal blood? Is the mother smoking? Therefore, is she transferring into the baby carbon monoxide on a regular basis? And you have to understand that carbon monoxide from smoking or from exposition in the environment has a preference for fetal hemoglobin. So if you inhale 1 particle of carbon monoxide, or if you inhale 10 particles of carbon monoxide, 9 will end up blocking the fetal hemoglobin and 1 will end up blocking your own. So carbon monoxide, for example, is a great cause of stillbirth in the UK. Does the mother have diabetes? That's a problem of vessels, high blood pressure, preeclampsia, we talked about it. Previous maternal medical history. Is there any abnormalities of the uterus? Is there any reasons why we think this placenta or this uterus are not going to function normally? And finally, what you can do is, usually there will be signs, even if you can't find any of these indicators, there may be signs that happen before labor. So usually, for example, before you start an induction, you will do a baseline measurement, monitoring of the fetal heart rate, a baseline cardiotocogram, baseline CTG. And so you can already see sometimes on this baseline CTG that there is some signs of antenatal hypoxia. We'll come back to those signs later. We can talk about abnormal biophysical profile, so that would be bloods plus blood pressure of the mother, like a lot of different indicators. Those can be seen, you can see gradual deterioration over time. So for example, the mother will not reach a blood pressure high enough to be called high blood pressure. So she will not have blood pressure above 14/9. But let's say that at booking, she had a blood pressure of 8/6. And over the course of the second and the third trimester, her blood pressure goes all the way to 12/8. That is a gradual deterioration, even though she does not meet the criteria. And that, in the same way we can think about decreased velocity, can be gradual signs that tells you more about the cardiovascular status of the mother and therefore the capacity of the placenta to extract oxygen. Now let's talk about the indicators of peripartum hypoxia. You need to think about it either in terms of sentinel event. There's a single event on a baby that was healthy until then, like placenta rupture, we talked about it. Uterine rupture, let's say that there is a scar on that uterus and the patient goes into labor. The strength of the contractions can break the scar. If you break the scar, it's like putting a dagger through the uterus. You're destroying the tissue. It bleeds internally. The baby and the mothers can go in shock immediately. That's uterine rupture. You can have cord prolapse. If you don't have the bottom or the head of the baby pressing on the cervix, it's possible that the cords goes through the cervix and goes inside the vagina. That's cord prolapse. If that happens, there's an immediate reaction, which is a natural reaction, which is that once the temperature around the cord changes, meaning the baby's born. That's physiologically, that should be the only reason why the cord is not within 37 degrees. If suddenly it's 32 degrees or less, and that can be the temperature of the vagina, immediately the cord compresses, there's no more blood flow to it. And so if the baby is still inside, and for some reason the cord passes through the open cervix and goes inside the vagina, the cord compresses all the vessels. There's no more blood flow. You have 3 minutes to get that baby out before there's any brain damage, because it's like holding your breath. This baby can hold its breath for 3 to 10 minutes before irreversible damage. Once you reach 10 minutes, it's irreversible damage to the brain. Maternal collapse, it's, for example, road traffic accident or any other cardiovascular collapse of the mother. Then, of course, there's no more blood perfusion to the uterus. That's a sentinel event. That's for acute events that can happen during labor. For non-acute event, usually you have to look at the CTG. You have to look at what is the biophysical profile of this baby and this mother, and what is happening. And do we see piling on, slowly but surely, small hypoxic event that becomes more and more severe, and do we act upon them? That's the idea. But again, you need to read that within the context of this mother and this baby. So is there a context of infection? If there's a context of infection, which in labor is called chorioamnionitis, meaning infection of the egg, the placenta, the membranes, the amniotic fluid, and the baby, then the consumption of oxygen of that baby is going to be much higher. That baby is fighting infection, that baby is running a fever, that baby is breathing faster, that baby has a metabolic rate that has increased, the requirements for oxygen are increasing, and if those requirements cannot be met, because that baby is having apnea for 2 minutes, 3 times within a 10-minute window, then that can lead to hypoxic event, even though that baby is healthy, of a good weight, and has a good placenta. Other signs, such as meconium, if the baby has passed meconium, that means that something has happened. Infection, severe hypoxic event, things like that. There are a lot of indicators that tell you more. And you need to understand always any hypoxic event or any labor, for that matter, within a broader context. I'm going to check that there's no questions in the chat or in the Q&A. Just bear with me. No questions yet. Perfect. Okay, now we've touched upon the CTG, but I think it's really important to understand it because this is where most disagreement within parties will appear. Cardiotocography, and the device is called a cardiotocogram, so you can use the word CTG for one or the other, is to be considered as the opposite of intermittent auscultation. What you can see at the top image is a penile stethoscope. If you use a normal stethoscope and you put it on the belly of the mother, what you will hear are the maternal vessels. You will hear the aorta, and you will hear the maternal heart rate. You will never be able to hear the fetal heart rate because the frequency is actually quite different. Therefore, you need a device that will capture an other bandwidth of frequency, and it's that one. It's the penile stethoscope, and it has not changed for more than 250 years. And of course, Pinard was a French obstetrician. He's the one who invented it. Even in the UK, you use the word penile stethoscope. I had to say it. I'm French. I'm sorry. So if you are a low-risk patient that is cared for in the midwifery-led unit of your hospital, whether it's called birth center or not, you will have intermittent auscultation for 1 minute after each contraction, or at a minimum of every 15 minutes during labor, and then for 1 minute every 5 minutes after contractions within the active phase of labor, when the mother is pushing. That is intermittent auscultation.
May I quickly jump in? We do have a question, and I know you asked for people to jump in. Nicola Kitchener has asked, how do you tell the difference between hypoxia injury and stroke?
Okay, so hypoxia injury and stroke. Stroke can mean the same thing as hypoxic injury. Stroke means a vascular event within the brain. When you have a vascular event within the brain, it can be led to two mechanisms. Either it's hemorrhagic, a vessel burst, and that's related to too high blood pressure, or trauma, or there was not enough oxygen within that blood, and that's a hypoxic injury. So stroke can be hypoxic, but can also be hemorrhagic, first of all. Second of all, a stroke that is hypoxic and a stroke that is hemorrhagic absolutely do not look the same on the MRI. Completely different patterns, completely different signs, and they usually do not appear in the same area, because to have an hemorrhagic stroke, you need to have vessels that can. You need a certain type of vessel. I'm not going to go into the definition exactly of all the vessels and all of that, but you need a certain type of vessels. And to have a hypoxic stroke, you need to have neurons that are more susceptible to decreased oxygen. And so actually, they're not exactly in the same area either. One is a vessel problem, the other one is a neuron problem, when you have neurons that cannot withstand the decrease in oxygen. So they do not appear the same. They're not in the same area. So that's for that. So technically, hypoxic injury can lead to a stroke in certain contexts. Now, hypoxic injury can lead to stroke or can lead to other effects. And you will see that you may have a normal MRI and you will still have EEG abnormalities because you don't have a metabolic injury to the neurons big enough that it is macroscopically visible in the architecture of the neuron and therefore on the MRI, but big enough that it has modified the metabolism of those neurons. That's epilepsy, that's modification of the EEG, and that can lead to functional problems. So in a nutshell, Stroke can be related to hypoxia, but can also be related to a hemorrhage. Stroke can be antenatal, peripartum, or postnatal. When you have a hypoxic injury, it can lead to stroke, but not always. And they usually are not, if you are trying to differentiate them, what you're going to do is you're going to do an EEG, you're going to do an MRI, and you're going to do clinical, you're going to look at the clinical impact that it has on that baby. What is the neurological impact that it has on that baby? Because it's not the same, usually not the same times of neurons, depending on the moment and depending on the mechanism. I hope that was clear. So let's go back to CTG. So if you think about CTG, you think about one, you think of it as the opposite of intermittent auscultation. You will also have the free birthers who are going to deliver without any sort of support from the medical system, and that's why not? Oh, I'm realizing it's already been 40 minutes. Oh, wow. I speak way too much. I'm sorry. Okay. So what's important about CTG? It measures the fetal heart rate and the uterine contractions. Now the new devices are looking at maternal pulse at the same time. The whole idea is being that there's been several cases where the fetal heart rate was poorly monitored, and actually you were monitoring the maternal heart rate. If you monitor the maternal heart rate, that can lead to false negative or false positive, and therefore the wrong care. So now most machines, and I would say it should be the case that all machines are measuring at the same time the fetal heart rate and the maternal pulse, so that you can very easily see that they are different. The core features of the CTG are baseline. What is the baseline rate? What is the variability? What is the fluctuation beat to beat? And what is their cycling? This variability should change regularly. Are there accelerations or decelerations? Those are small pictures, just so that you understand them. Baseline heart rate is, you can see in this picture on the left, is around 130. And you may have unstable baseline, and that needs to be understood within the context. Unstable baseline can be normal or not normal. This is a normal variability. A reduced variability is not enough variability. Variability is really, really important because it's the sign that the brain is functioning normally. It's the signs of the opposition of the sympathetic and the parasympathetic system. If you're running, your heart rate goes up. That's your sympathetic system kicking in. If you're sleeping, your heart rate goes down. That's your parasympathetic system kicking in. Your heart rate, just like the one of your baby, is variable over time because both are present at all time at the same time. If you have reduced variability, that's a big problem. That means that one or both of your sympathetic and parasympathetic are not working. Sinusoidal pattern, we're not going to talk because it's not really relevant, and I've been talking way too much. This is an acceleration. So the heart rate increases for more than 15 beats per minute for more than 15 seconds. The other one is a deceleration. It decreases for more than 15 beats per minute, and for more than 15 minutes. And those decelerations, how they are, what they look like, is there variability during the deceleration? Is there increased baseline, change baselines? What are they compared to the contractions? All of that needs to be read within the context of this pregnancy, this mother and this baby, all of together, to be able to determine whether there are signs or not of hypoxic event. You can see here what looks like a gradually progressive hypoxia. You have big decelerations with a progressive rise in the baseline. There's a decreased variability during those deceleration, and those are actually each of the contractions. That is gradually progressive hypoxia. And you see here an acute hypoxia. The baby was fine. There's been a long contraction that lasted, you can count here, this contraction lasted for 6 minutes. So this baby was without oxygen for 6 minutes. And you realize that this baby had was not able to have any compensation because this baby had some form of antenatal injury already. And so this baby just crashed, went into cardiovascular collapse. That's what you see by the fact that the heart rate is just going down and not going back up. CTG does not directly measure oxygenation. and is not a diagnosis for hypoxia or brain injury. What we're doing is we're looking at downstream information, cardiovascular information, pressure, or at least a proxy of the pressure inside the uterus by measuring the contractions. But actually, you don't know. You can have contractions that are very well defined on the CTG and have a low amount of pressure inside the uterus, or vice versa. You may not be able to measure those contractions because the mother has a big belly and or a certain weight, and so actually there's a very high pressure environment inside the uterus, much higher than the blood pressure of the mother. We've talked about that. And so there are high limitations with the CTGs. There's high false positive rates, there's low specificity, there's a high variability between observer or the same observer. If you take the same CTG during your night shift at 3 a.m. and you show them a week later to obstetricians when they're well rested, they will interpret it differently because they have the capacity to treat more information at the same time. And what's really interesting about CTG is that CTG during labor is associated with reduced rate of neonatal seizures, but no clear differences in cerebral palsy, infant mortality, or any other standard measure of neonatal well-being. So CTG has had an effect, but much less than what people think of. And that's in the Cochrane. That's nice. Everyone knows that. The guideline committee concluded that the use of CTG in labor leads an increase in the number of interventions without a concomitant increase in positive neonatal outcomes. That is the most mind-boggling. And so when you look at the CTG, 1, it's difficult to interpret. 2, it's difficult to interpret live. It's much simpler to interpret once you already know what's happening at the end, and once you have once you're rested and you don't have the stress of the mother bleeding at the same time, the husband screaming because he doesn't understand what's happening and all of that. So it's always easier to look at retrospectively. And if you look at a very clear pathological CTGs, only 50% of fetuses that have a very clear pathological CTGs will have hypoxia. The other ones, we don't always know why the CTG is pathological. And so that leads to a lot of interventions. So CTG is where you will have all of the fights. I'm going to glance over this. There's 3 ways to look at your CTGs to categorize it between normal, suspicious, and pathological. You can follow NICE guideline, you can follow the FIGO guideline, or you can follow the physiological approach to CTG. Yes, Nicolas, there's been multiple attempts to develop AI in CTG during labor. It is in progress. The problem is before this arrives at the bedside, there will be 15 to 20 years. It will take us 5 to 10 years to develop it, and it will take us 5 to 15 years to validate it and make it safe enough that it will replace human intervention. I will go over those classifications. Now, the report from 2010, looking at 10 years of cases. Was there a misinterpretation in the CTG? Yes, in 80 to 90% of cases. If you look at once the judgment has been adjudicated, what is the themes of misinterpretation once they have agreed between the different experts? Failure to recognize abnormal CTG is the most common. Failure to act on an abnormal CTG is the second most common, and that is all about human factors. And we have a slide on human factors a little bit after. Failure to refer, failure to monitor adequately, or inappropriate use of syntocinon are the 3 next ones. So let's talk about the most common interpretation errors, because that is what will lead to disagreement between your expert and the other party's expert. 1, sometimes the CTG is read alone without looking at the entire clinical context. We've talked about all the different signs of all the different possibilities of antenatal injury that happened at the level of the mother, at the level of the baby, at the level of the placenta, all of the things that you can look into that will give you information. And sometimes it's only looking at the blood pressure at booking, looking at the blood pressure before labor, realizing that actually there's been an increase in that blood pressure, but that blood pressure is still not significantly high enough to be considered high blood pressure. But you can already tell that on the maternal cardiovascular side, there have been changes during this labor that makes it that this placenta has required a higher blood pressure. Sometimes there's over-reliance on a single feature. The most important feature is variability, always. But sometimes you think too much about the baseline or things like that. Failure to recognize deterioration over time. And that's the reason why in the UK there's what we call fresh eyes. So every hour, someone who is not in charge of your patient will come and check your CTG. They will have a fresh eye. Because if you're sitting in the room and you're watching the CTG as a midwife continuously for 12 hours, you may not realize that slowly but surely the dislocations are becoming deeper and deeper, or that the baseline, effectively is going higher and higher. Misinterpretation of decelerations. The classification of deceleration is complex. Failure to escalate, meaning, oh, it'll become fine later. It's okay. It's still acceptable for now. I have said this CTG is suspicious, but I don't feel that it's that suspicious that I need to call the doctor yet. Delay in escalation. Doctor is stuck in theater. Or documentation gaps, always. At the end of the day, documentation gaps are, I haven't had a single case where there was no documentation gap. And we can go back to your question. I am currently working on an article on does AI scribe improve the medico-legal protection with regards to the absence of documentation gap. Now, let's talk about human factors. Why is in this slide the second factor failure to act? Why? Because if you've said there's an abnormal CTG, therefore there's a suspicion of hypoxia, you should be very clearly be able to say, oh, I'm gonna either call the senior midwife, call my colleague, call someone. That seems logical, but that's where human factors come in. So there's conversations about anchoring bias. So it was initially normal, and that impression persists because in your mind, it's a low-risk patient and things were fine at the beginning. Now it's a little bit worse, but it was fine at the beginning. So why worry? Confirmation bias. It's like, yeah, but the variability is still normal. Yes, there are decelerations, but you still have, which is the most important, is the variability. So I will look for the things that confirm what I'm already thinking. There's normalization of deviance. We've talked about it, that over time, you may not see that it has changed, but you register it as almost the same as before, rather than saying, oh, it's different. Of course, workload environment, high patient to staff ratio, simultaneous clinical demands. The reg is called in A&E to see an ectopic pregnancy, in labor ward because there's an abnormal CTG, and on the ward because there's a patient vomiting, and they are distributing only 5 minutes to each of those patients, whereas actually the clinical scenario should be that they should go to A&E first because an ectopic pregnancy is way more at risk than the patient who's vomiting on the ward or a simple abnormalities on the CTG. Interruption and task switching, same problem. Communication failure, lack of clean ownership of the CTG. Let's say that the midwife is during her pause and during her break, her lunch break, and another midwife is in and she's like, oh, it'll be fine. You can wait until the other midwives come back. Poor escalation is, I've called the senior midwife is busy, and therefore I'm waiting for her to come back before I call the doctor. Reluctance to challenge senior decision. That's a hierarchy and culture problem, which happens a lot. And delayed escalation due to perceived authority gradient, which is, I've called the junior doctor is going to come. It's becoming worse and worse, but he's going to come. So I'm not going to call the consultant right away because there's an authority gradient. I should not go directly to the consultant, whereas actually you should. If this junior doctor is busy and he can't because he's dealing with the bleeding lady in A&E, then you should call the consultant directly. Those are cultural effect. And we can talk about the impact of, we don't have the time, but we could talk about the impact of culture within a trust, of a lot of different things on how that impacts the human factors. We can skip that. Adjunct exploration. There's other ways to look at the presence of hypoxia. The most common that you're going to see is fetal blood sampling, which is making a little hole on the scalp of the baby, capturing the blood and looking at the amount of oxygen, the pH and the base excess inside that blood. It was done between 2007 and 2022. That's when it was within the NICE guideline, but it was actually done before. It was in the NICE guidelines in a lot of centers, and it was continued to be done after it was removed from the NICE guideline in 2022 in a lot of centers. So fetal blood sampling will appear in a lot of cases.
Hi, sorry, Benjamin,
Yes.
just to jump in here. Might I make a suggestion? This has been absolutely riveting, although I appreciate people may in the near future need to race off. I know you have a few slides a little later on regarding the clinical areas, such as where you were in terms of the common areas of dispute, and things you've seen in practice, both clinically and from a medico-legal perspective, that would be important for our listeners to hear about, and perhaps another 5-10 minutes, if you have the time, would be great, and our viewers
sorry,
could
everyone.
stay for that.
I'm rambling. So we're going to talk about common area of dispute, and then we're going to talk about one vignette, which is a case that was adjudicated in 2024 based on a case in 2022, so that we can talk about it. There's a question from Nicole. I appreciate that this may depend on the number of temporary hypoxic episodes, but can brief episodes of hypoxia happen without causing metabolic acidosis? Yes, as long as the baby has a good baseline and the baby has the capacity to compensate. We've skipped the slide on compensation and decompensation. So if the baby has has a good metabolic baseline and good reserves of energy, a baby can withstand during a normal labor a lot of hypoxic episodes. Absolutely. So most common areas of dispute. One, the CTG interpretation. As I've said, CTG is difficult to read, and we know, it is well known, that there's a high level of inter-observer variability. So when two people look at the CTG, in 40% of the time, they will disagree on the classification. And this can come also because of the type of framework that they use. Is it NICE? Is it FIGO? Is it physiological CTG reading? The second one is the timing of the hypoxic insult. Is it antenatal versus intrapartum? There will be a lot of discussions on, actually, there was some level of hypoxic insult antepartum, and there was some level of hypoxic insult perpartum, because let's say it was an SGA baby, so a baby that has growth restriction because of placental insufficiency, and then you add on labor. How do you distribute the quantum on a question like that is very difficult. And so you may have one expert that says it's mainly antenatal and one expert that says it's mainly perpartum. There's discussions around recognition and escalation. As I said, escalation can be complex because of who is busy, when and how. You know that you can call the senior midwife, you know that you can call the SHO, you know you can call the reg, you can call the consultant, you can call the anesthetist, you can call even external consultants if one consultant is in theater doing a hysterectomy to save the life of a lady that is bleeding. And sometimes you will have to call a consultant that is not on call, but because there's no other options. But how do you navigate all of that decision is not always easy. And sometimes it's very clear, but actually if everyone's busy, what do you do? And if you're a midwife on your own, in front of a hypoxic baby, or what you think is a hypoxic baby, how do you escalate is not always straightforward. Timing of intervention, we've removed the entire slide around timing of intervention. Of course, all the slides will be provided to you at the end, so you can come back. And I'm always open for discussions. So if you have a question, Leo and the team have my email. They will provide it to you, and I'm happy to sit down with you and have a conversation. timing of intervention, is it something that is it a baby that needs to be delivered within the next 10 minutes, within the next 30 minutes, within the next 2 hours? That is something that is not always clear, because it's very clear if there's a crash event, this baby needs to be delivered within the next 5 minutes. Great. You know that. Everybody's running. It's very clear for everyone. But is it a baby that can be delivered in the next 45 minutes or in the next 2 hours? That makes a huge difference, because if it's 2 hours, you can wait for the doctor to finish their cesarean section and come back. If it's 45 minutes, then you don't have that time. But you're not either going to press the red button and say, we need to run to theater and open another theater, because it's not that bad either. So it's sometimes those are quite difficult to navigate. And if you don't put very clearly why you thought that way in your notes, then you're going to have more problems. Finally, the different evidence may not all go in the same direction. You may have clinical context, cord gases, MRIs done at day 5 or day 10, and CTG, and you may have different bundle of information that go in one direction and another group of bundle of information that go in another direction. And then what do you do with that? And that's very difficult to, again, distribute the quantum of injury between the antenatal care, the perpartum care, and the postnatal care in NICU. So all of that are areas of very common areas of dispute. And I'm going to go very fast through this case, which, as I said, has been now fully adjudicated. It's an open case. It's CNZ versus Royal Bath Hospital. And in that case, there was a disagreement between the two experts, obstetric experts, not between the obstetric experts and the neonatal experts or the neurological consultant later on in life. It's in between the two obstetric consultants. And the way Justice Ritchie analyzed the information is very clear. He put it all in the case. So it's really interesting. So this case is, you had twin vaginal delivery. The patient was very well consented before. She understood what was going to happen. The first baby was delivered vaginally without any problems. And then the situation deteriorated once the first one was delivered. And there was a delay of transfer of the mother to theater. And there was a big intertwin delivery interval and a second twin, which was born in very poor condition. And this second baby developed HIE and then a very severe case of cerebral palsy. That happened in 2022. And now the core question was, when did the HIE occur? And would have an earlier delivery and a smaller intertwin delivery interval made a difference? You had the claimant expert that emphasized that the need for speed in between the both delivery was really important. And you had the defendant expert that said there was no urgency or a low level of urgency because the CTG had been completely normal until the end of the delivery of the first twin. And so they suggested that the delay was acceptable because the second twin had demonstrated very good metabolic reserves during the entire labor and the entire delivery of the first twin. And this is what Judge Ritchie said, which is really interesting, is I consider that both obstetric experts were impressive and helpful witnesses with substantial experience. But I was particularly impressed by Mr. Forbes' depth of thought. Other than some minor errors on figures carried over from a large volume of relevant textbooks and articles, blah, 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 I preferred his analysis of the events and the standard of care of the obstetric clinician involved. I found that the other experts' evidence was more general. The second expert provided no textbooks or article to support his evidence, and on the CTG trace and the timings and the things that should have occurred. Mr. Tufnell, the second expert, was there evidence that there was no rush between the fetal heart rate, because the fetal heart rate was reassuring on the CTG, evaporates in logic when the CTG was removed in between the two. And there was a 30-minute gap where the CTG of the second twin was not measured. He also says that the second expert did not address a point that was addressed by the first, which is the Rayburn paper, And I will analyze further in the next slide, and then that will be done. So what the judge thinks about a disagreement is that he preferred very clearly one expert based on the quality of the reasoning and the level of evidence to support their claims. He looks at the coherence of the logic during the entire chronology and applies not selectively in time, but during the entire chronology, the value of each reasoning in that case. He looks at the engagement of each expert, both on key issues and omission. And he says very clearly, the second expert did not look at the negative sides, what was omitted. He only looked at what was present, which is a very selective view to look at this case. And he says, Judge Ritchie says, that there is value in addressing the opposing arguments, which the first expert had done. He said, this is all the points, and this is all the points that disagree with my statement. And this is why I consider that they are less valid than the points that I've taken that agree with my statement, which was not done by the second expert. And finally, the judge, at the end, rejects completely the second expert opinion, while recognizing that he is working well, has done a really good work, has a good experience, and simply because there are scientific limitations and point of views of explanations in between experts. And so my last slide, and then Leo, I'm sorry for having gone over time, but my last slide will be a quick checklist. The way I saw that the Judge Ritchie looked at the opposing opinions of both experts. He looked at one, logical coherence, that the explanation follow a clear causal chain, and is that chain supported by reference to articles, guidelines, and all that is needed. The consistency with the records, is that logical chain consistent with all of the information that we have? Clinical plausibility, does it reflect the literature in the real-world obstetric practice? Resistance to cross-examination. Once you look at omitted elements, once you look under challenge, does the opinion collapse? And finally, avoidance of hindsight bias. We haven't talked about it, but there's a little bit of that. Like, is the expert reasoning more prospective or retrospective? It's less coherent in that particular case. And I think that is all for today.
Well, I have to say, Benjamin, that was extremely detailed and fantastic. A really excellent talk, and there's a few messages coming through already to reflect that. If there are any questions that people would like to pose, now is the time to get into the chat and to put something in. I'm sure we can get to a couple of them if there are any right now. And I think this was incredibly insightful. Before we jump to any questions, I just want to highlight our next webinar in the INNEG series. We are jumping back to a personal injury focused webinar with Dr. Rupert Wharton, Mr. Rupert Wharton, a trauma orthopedic hand specialist who spoke a couple of years ago to everyone. And he's coming back a couple of years later to talk again on common injuries and functional limitations. So join us for that if you haven't already. I'd just like to ask myself, is there any one thing that you might suggest that solicitors should be taking account of if they're reviewing the records of a potential birth injury case prior to sending it to an obstetrician? Is there one single thing that you might suggest that they look for as a red flag, so to speak?
So you want to be able to assess the entire picture. And so you want to make sure that you have all of the antenatal care, all of the scans, all of the CTG. And I've sent a report, something like a month ago. Yeah, a month ago. And the entire claim from the claimant resides in elements that are in none of the notes, because it's all about conversations that happened in the corridor with nurses and doctors, and none of the things that are claimed are substantiated in the notes. And so it's really important to have all the notes, all the scans, all of that. I think you all knew that, but I think it's, if you end up with claims that are based on unsubstantiated, and by that I mean not that they didn't happen, but that there's no notes of them, it's very difficult to make a claim in that case.
Thank you very, very much. And I think there's no immediate questions, but everyone should be aware that Dr. Benjamin is available for any further questions on case-specific matters. And obviously, as he mentioned earlier on, you're able to email him. Details and CV will be made available together with the recording and the slides in the next couple of days following this event. And just to say again, thank you very much for your time today. We really appreciate it. It's been incredibly insightful. And I think we will have to get you back very, very soon for the follow-on to continue what was an incredibly insightful and interesting webinar. Thank you very much, everyone, for attending today at today's INNEG webinar. And we look forward to seeing you at the next event. I'm going to close off the session and wishing you all a great day.
Bye, everyone. Thank you very much.